Welcome to Major's docuseries on health entrepreneurship. Entrepreneurship in healthcare is vital for addressing Africa's unique challenges and creating sustainable solutions for communities across the continent. In this series, we explore the journeys of three extraordinary leaders: Dr. Clarke, an Irish-Ugandan physician, entrepreneur, and philanthropist who founded the Chiwoko Hospital and the International Medical Group in Uganda; Dr. William Mapham, a South African ophthalmologist and founder of Vula Mobile, the oldest African health tech company connecting hospitals to specialists; and Tonny Natif, a Ugandan pharmacist, activist, and founder of Garden Health Pharmacy, one of the largest with over 19 stores. Their stories reveal the lessons, challenges, and triumphs that define healthcare entrepreneurship in Africa. Through their experiences, we aim to inspire the next generation of changemakers in healthcare. In the ever-evolving healthcare landscape, strategy is the cornerstone of success. These leaders share their approaches to developing and implementing strategies that have allowed their businesses to thrive and create remarkable impact.
In 2014, I also started my registrar program and started specializing, and that actually really helped. So my prof was actually quite a big fan of Vula, or at least the idea of Vula, and he supported the rollout of Vula in the eye department at Tygerberg Hospital, and that's where it first started. But to give you kind of a funny story, we launched in August 2014, and I was so excited. I was totally convinced everyone would download this, we would get going. I mean, it makes so much more sense, but actually no one used it. And it took until October of a lot of user experience testing with students for the first people to start using it. So I guess what I thought was the solution initially wasn't good enough. And it was only through user testing that I realized what the solution needed to do. So yeah, it did take some time and some pushing at the beginning of that. And then my prof in 2015 very unusually organized for me to take 6 months unpaid leave from the hospital and from the registrar program to see if I could raise enough money for Vula to grow. And so very grateful to him for making that possible. And it was within that time that I managed to get enough funding to keep Vula going. Yeah. So I think that it's never been easier than now to launch a tech product, because you can almost do the programming through ChatGPT. There's so many off-the-shelf solutions you can twist to what you want to do. So I really think that you should just go and test whatever you want to do. The hardest part with technology is not the technology, it's actually the behavior change in medicine, because you're dealing with quite a conservative environment typically. It's not built for innovation. If you think about a new drug, you can't just have a new drug and then go around treating everyone. You have to go through drug trials. And it's the same thing with digital health. Everyone will be waiting to see, is there any proof that your system actually works? So I think it can take a long time for a health intervention to get traction. So I think that if you've got young people listening or wanting to learn, just go and do it. Find a way to make whatever you want to do. It doesn't have to look pretty or anything, but just test it as soon as you can. And that doesn't require that much funding. If you want to build a whole company, that's a different question. I think that one of the things I learned was that when in that 6 months I took off as being a doctor, I did a course called Lab to Market. And Lab to Market was actually for engineers and for scientists who were busy coming up with inventions and creating patents, and then wanted to go to market with their invention, literally lab to market. I think I was the only medical person on the course. And what was so interesting is that during the day, they would give us lectures on, well, first of all, you have to raise money from friends, family, and fools, and then you have a seed A, and then you have a seed B, and this is how it works. And at the end of the day, they would invite an entrepreneur who had actually made it. and had a successful company, been in existence for more than 5 years, to give a presentation, and none of them had done it that way. So all of them had found a unique way of starting their business and making it work. So the way that I've started doesn't mean it'll be the same for you. Each of you will find your own way. And there are some principles, but I think that just because they're rules doesn't necessarily mean you have to follow them blindly. I think that if you ask people for advice, people will help you on your own journey. And I think it took me a long time to learn to ask for help more. And if you look around, there are a lot of organizations that will help you. There's the Health Tech Hub in Rwanda and Kigali, for example. That's just one. And also just reaching out into the ecosystem, people like me or others who can help guide you on your journey, because I think each of you will have an individual one.
The first thing that I did was in Chioko Hospital, we went out and looked for donors to support it. So in Chioko Hospital, it's 70% supported by donors. But when I started then in the clinic, I didn't have any donor support, so it had to come from the patient fees. And that really is a real test, you know, like, okay, yeah, I'll get 100 patients lining up when it's free, but, you know, if I'm charging you, you know, equivalent of $15 or something for your consultation, how many people will show up? And so that really is that's a value, put a value on my time. And it was interesting because, you know, as my reputation built up, people were prepared to come and pay. And then I was able to reinvest that into developing the facilities. But basically I started feeling that there wasn't any private hospital at that time. And I started saying that, and there was a lot of clinics, but they were very lousy quality. And things like hygiene were very much lacking. So I felt, you know, this may be poor, resource limited country, but it doesn't mean that you have to be second rate, you know. Developing country doesn't mean second rate, it doesn't have to. Yes, I can't put in the latest MRI and stuff, but I can do evidence-based medicine. I can do best practice, I can do good hygiene, you know. It doesn't take money to do that kind of stuff. So I thought if I did that, it would also be in terms of quality, it would be setting standards for how private hospitals should develop. And that's actually what happened. And there was many people who worked for me and worked in the organisation. People like Joel Aroni now who are in Mengo, Andrew Sestalco who runs in Zambia, they all work for me. They're my people that I've seeded out into different other organisations. And you'll find a lot of their experiences come from stuff that they would have learned from me. I sound like I've got a big head, but it's not that. It's just that if you put emphasis and say, look, we need to do quality, then it's not about, you know, we need to make as much margin as possible. Yes, you will make money. And I had a lot of conflicts with patients because I didn't believe that scanty parasites existed. You know, you either had malaria and you'd seen it, or you didn't. But this idea that, oh, you have a fever, therefore it's malaria, therefore everybody at that stage, this is some years ago, everyone who walked in got treatment for malaria. And of course we got chloroquine resistance, now we're getting resistance into the other anti-malarial drugs. And I just felt it had to be evidence-based. And patients, that people would go to other clinics and they would tell them, oh no, you have malaria, you've got a bacterial infection. I can't stand this thing now where I see people walking around with Venflons in their arms. Why have you a Venflon and you're at work? You can take oral medication, you know? It doesn't make any sense whatsoever. Why are you going to a third line antibiotic when, you know, this thing is probably sensitive to so much cheaper antibiotic. So don't say because I've come to an expensive hospital, I'm just going to give an expensive antibiotic. It don't make sense to me. Use the scientific approach, be quality driven, be service driven. And it was a challenge. It was a challenge especially with the nurses, to get the nurses to. The big issue with nurses was that they didn't value themselves. Now this has gone back a few years, but what would happen is, you know, oh yeah, I didn't get into university, so I did nursing. Do you not value yourself? My Ugandan daughter here is the vice chancellor of this university. She's got a PhD from Yale. She's the first nursing professor. That girl was, I first met her when she was 16. She was a big woman. She hadn't any education. She couldn't even do O-levels because, you know, her father was being chased around the Luaro Triangle, you know, because the war was going on then. But she went and started with enrolled nursing, then went to the States, did her registered nurse qualifications, went on and did a master's, came back here, worked with me, went back and did a PhD. People can do it, you know, and Ugandans have one of the things, but a lot of nurses then, they weren't like Rose, they weren't motivated, they didn't believe in themselves, and the worst thing was the patients didn't believe in them. Patients were down on nurses. When the doctors came, oh yes doctor, it's okay. When the nurse was there, you know, they didn't value nursing. My other daughter has got a master's she's got a master's in social history from Edinburgh University. Then she did her registered nurse in Queen's University, and then she went on and did a couple more degrees, and she's now like a specialist cancer nurse. And she's like, if I need to know anything about blood cancers, I call her on. Very smart, she's a nurse. You know, it's a career, it's something you can be proud of, and I'm glad to say it's changed now. I see very, very good nurses, very specialist nurses, but IHK was we were the first people who sent batches of nurses off to India to learn ICU, you know, and then got nurses to value themselves. But at the time, man, you know, that's why I started a nursing school. Yeah. A guy walked into my office, actually it was just closing up, so it was like 7, because I would work, you know, in the mornings, and then I would be, at lunchtime I'd be doing other things, and then 4 o'clock to 6 o'clock, like that was my evening office hours, or 7 o'clock. So it was about 7 or 8 o'clock I was closing up, and this guy came in and said, would you be interested in doing capitation? You know, treating patients in capitation, and I'm kind of like, what's that? And capitation is basically where you receive a certain amount per year and then you look after that patient. So it's a kind of insurance. And he was the HR manager from the American Embassy, which was a lot smaller then than it is today. And the international people all had their international insurance, but the local staff, they wanted to provide a medical benefit for them. And of course they were finding this thing where people were bringing back false receipts, and they were going to a clinic and inflating the price. And so he knew, you know, from his American experience that you could do what he would call an HMO model. So he would pay a provider. He'd say, we've got 100 staff here, we're going to pay you $200 a year and per person, and we pay you on a quarterly basis, and you look after their medical needs. And that was mainly outpatient services. If they went into hospital, I would follow them up, but I didn't have a hospital then. And he said, I've been around all the clinics, nobody wants to do it. I said, why? I said, because he was offering something like $160 a year to look after a patient. And so guys would sit down and go, but if this guy comes 5 times a year, I'll have lost money, because $40 a consultation and drugs and stuff like that, and then he comes 5 times, no, I lost money on it. But my calculation was completely different. I had the setup, I had the infrastructure there, I had the staff, I had everything. So the only thing that his $160 was costing me was the marginal costs. The drugs, the lab tests, that was it. Otherwise I was there, my time was still there, my nursing staff were there, you know, and so I reckoned if I was getting $160 a year, I was for 200 people, whatever it worked out to be, I was meeting all my fixed costs immediately, and I could make my, you know, so I was like, yeah, I'll do that. That became the basis of my insurance. Then I opened an insurance organization, sort of modeled on what AAR were the first people who did. But it was basically on the basis of this American embassy contract, and then I started to sell that to other companies, and it was a kind of a medical insurance, but it wasn't really quite medical insurance because you came to my clinic for the treatment. But that was one of the business aspects that really helped me to, because when people are paying school fees, they don't pay clinic bills, so that your income goes like this, yeah. But when you have a fixed income coming in from a corporate organisation, in fact you'll find now that sometimes in the international medical centres, probably 80% of their income is coming from medical insurance. But it wasn't called medical insurance.
Around 2015, Solomon gave me a scoop. Remember my campus roommate, National Drug Authority is going to stop licensing pharmacies in all the busy places in Kampala, so you might as well get yourself all the pharmacies you can find before we stop that. That was good advice, but it was potentially bad advice, because I was running this company alone, no board, no CFO, no nothing. As the accountant, the human resource manager, all that stuff. No corporate governance structure, which I really encourage any healthcare entrepreneur to embrace now. With the benefit of hindsight, I survived, but I don't want you to reinvent the wheel. It's dangerous. So we went on rampage. Around the time we bought all manner of pharmacies. Not Ginger. We bought pharmacies in many of these places, and in fact when you look at Guardian Health, it has the best locations of any retailer in that space, not by accident. It's because we set out to open these pharmacies, to buy these pharmacies, and we quickly ran out of money. We would use supplier credit. In the business of pharmacy, usually when you get a good location, suppliers will give you all the meds you want, and you will negotiate the time within which to pay. Usually it's 60 to 90 days. So if you can turn around that money within 90 days, you run business with working capital that belongs to other people. But then if you divert that working capital to expansion, you're going to default on your obligations to pay your suppliers, you're going to default on your obligations to pay your landlords, you're going to default on your obligations to pay your employees and all that stuff. You don't want to be there in business. And so we came close to that, and more even. Not because what we're doing was not profitable, but because we just expanded too fast and we had no board, we had no numbers guiding our expansion. So we quickly ran out of money, but we had very good locations. Banks couldn't loan us money. Even the banks that would previously see our turnover in the excess in billions, they couldn't even loan us 500 million shillings, which was a shame. I remember one time I went to a bank, approved a 500 million shilling loan facility on a Friday, and on Monday they pulled it saying, we had checked your account and you had a bounced check. Because we'd secure our credit with open checks, you just sign the check, no debt, no amount, just knew that you trust your supplier. So one of those suppliers, knowing that we're struggling, just put whatever amount in the checks and banked them, and they bounced and came after us using police and what. One time they actually locked me up in CPS over that same bounce check. That was at the time when I was trying desperately to raise financing for the company. So those are the scars in entrepreneurship that people never talk about, but the rough times. So anyway, imagine you've already told your suppliers, I'm going to get money on starting Monday and hopeful, and then Monday you walk into a bank to sign an offer letter and they're like, sorry, that's off. So we had to be creative. This is now 2016, towards the end. I'd been approached by a private equity fund that had initially wanted to invest, but I got their letter of intent and did get back to them. This time I had to humble myself and go back and go like, guys, remember that other bullish company that you came to and it didn't give you the time of day? Now we're back, we need money, but actually we are now making losses. It's a very tough situation to negotiate from. So anyway, they agreed to do due diligence on us and invested in a setting where most funds wouldn't invest, so I give them credit for that. So they came on board, agreed to invest $3 million with us. April 2017, our turnaround starts, but not without pain. Usually when you get new partners on board, they don't understand your business. They may understand business, but they don't necessarily understand your business, and you're two proud people. And you're also just learning to work in a formal corporate governance structure. So we fought quite a bit, nearly lost the company, but then eventually we organized ourselves and built it back into the brand that it is. It's now probably the most recognizable retail pharmacy brand in the country, which is fantastic. We serve millions of prescriptions, and from a public health perspective, I'm sure my people at the University of Washington aren't disappointed that I threw away public health and went into business. I feel like, if you come from Africa, especially sub-Saharan Africa, where in some reports 30% of the medicines we use are counterfeit. So if you participate in building the supply chain for good quality medicines, I think that's at scale. I think that's public health in action. So I feel like private business can be a force for good in the public health space, and we've seen it play out. At least the story of Guardian shows that.
Hello, Mejo community. My name is David Julie Muganzi, and I'm part of the incredible team that is behind this work. Mejo is a brainchild of mine, and it's exciting to see that close to 3,000 of you across Africa have tuned in to watch the stories and engage with them. I'm here to request you to support this work by subscribing, liking, and sharing it with your friends. We want to reach as many health professionals across the continent, and you can help us in this work. We hope that these stories shall inspire people, give them courage and the motivation to change our health systems. And we have something exciting coming up. In the month of May, on the 10th day, we shall have our very first live stream session, Dr. Clarke. 20 of you shall have the opportune moment of joining in physically, and we can't wait to have. Look out for the registration on our pages, and we hope that your lives don't stay the same. Thank you.